Good morning, good afternoon, good evening, everyone. Thanks so much for joining us. My name is Becca Levine, and I'm a senior maternal health advisor in the Office of Maternal Child Health and Nutrition in USAID's Bureau for Global Health. On behalf of USAID, I'd like to thank the Momentum Country and Global Leadership Project for hosting today's webinar, and thank all of you for taking the time to join this important discussion on perinatal mental health. I'm planning to share a few opening thoughts as a perinatal mental health advocate with personal lived experience and also as a global health donor. So first and foremost, good mental health is a human right fundamental to the pursuit of a life of dignity, prosperity, and well-being. But the right to mental health and psychosocial well-being has long fallen behind physical health in attention, funding, and action, despite a massive global burden and unmet need. 1 in 4 individuals will experience poor mental health at some point in their lives, with 80% of these individuals living in low and middle income countries. Women are particularly vulnerable to mental health challenges due to varying biological factors and social determinants. In fact, many are unaware that common perinatal mental health disorders, such as anxiety and depression, are in fact the leading complication of pregnancy and childbirth globally. We also know that poor perinatal mental health poses significant and lasting implications that negatively affect women's health and quality of life, and the overall health and development outcomes for newborns, infants, and children. Despite this, perinatal mental health remains absent from large-scale maternal and child health policies, initiatives, programs, and services. If we are to come close to achieving the Sustainable Development Goals, perinatal mental health must be incorporated as an integral part of maternal and child health policies, plans, programs across the globe. USAID recognizes that healthy women and families are the cornerstone of an enduring and prosperous society, and that investing in mental health now can put us on a positive path for the future. For every dollar invested towards improving mental health and well-being, $4 are returned. So at USAID, we have elevated perinatal mental health as a strategic priority for increased focus and investment over the coming years. In particular, we plan to play a key role in advocacy and awareness raising to support recognition at the highest international and national policy forums that mental health and well-being needs to be a critical component of maternal and child health programming. We want to support enabled policy and programmatic environments inclusive of appropriate financial and human resources for implementation at scale. We want to support the destigmatization of perinatal mental health and mental health more broadly, improve data on and measures of perinatal mental health, and help to build a robust evidence base of interventions and integration approaches that are cost-effective, feasible, acceptable, and scalable. So now that I've done my little spiel, I want to mention a few logistical notes and then introduce our truly stellar group of speakers for today. First, we'd like to ask that you all please use the chat function to introduce yourselves with your name, your organization, and your location. And if you can go to the agenda slide, I can provide a very brief overview of the agenda for today's webinar. We'll start by setting the stage on what the evidence is telling us about the burden in LMICs and the impact on women, children, families, and communities. We'll provide an overview of current implementation of programs to address perinatal mental health. We'll introduce a newly human-centered design global theory of change for perinatal mental health. We'll then have an open question and answer session followed by a moderated discussion with panelists. And finally, we'll have a few closing remarks about the way forward. So please feel free to use the Q&A box to ask questions throughout the webinar, as we do have time set aside for that. So now, without further ado, I'm really so pleased to introduce our speakers for today. Dr. Jane Fisher, who's Finkel Professor of Global Health at the School of Public Health and Preventive Medicine at Monash University in Melbourne, Australia, and one of the world's leading experts on the social determinants of perinatal mental health. Shannon McNabb, Senior Technical Advisor with Momentum Country and Global Leadership. Mr. Linus Muvu, Chief Team Leader at the Society for Pre- and Postnatal Services in Zimbabwe, and founder and chairman of the first ever Afrocentric International Conference on Maternal Mental Health in Africa. Aditya Prakash and Rohan Patankar, Senior Design Researchers at Quicksand, a human-centered design organization in India. Laura Fitzgerald, midwife and senior technical advisor at Momentum Country and Global Leadership. And last but not least, we'll hear some closing reflections from Suzanne Stalls, the maternal newborn health director at Momentum Country and Global Leadership. So thanks very much for the opportunity. And Jane, please, over to you.
Thank you so much, Becca. And if I could have the next slide, please. Could someone advance? I wanted to start with a very short history that mental health problems associated with childbearing have been documented for more than a century and a half and were first written about in the 1850s in England and France. In the next slide, please. In the world's high-income countries, we now have copious epidemiological evidence about prevalence, risk, and protective factors for these problems, evidence to inform clinical care from diverse perspectives, and we also know about the importance of primary and secondary prevention and universal schemes to improve the mental health of women who are pregnant or who've recently given birth, and the health services needed to support these. Next slide, please. There's general agreement that there are three conditions of interest. The serious or severe mental disorder of postpartum psychosis occurs at about the same prevalence worldwide in low and middle income countries as well as high income countries of about 1 to 2 per 1,000 births. Most women have some period of emotional adjustment after they give birth, which is called the third day or postpartum blues, and these tend to resolve with routine care. But I think what's concerning all of us is the prevalence of what are called the perinatal common mental disorders, and these include depressive, anxiety, adjustment, somatoform, and post-traumatic stress disorders, which have a large degree of symptom overlap and can be difficult to distinguish from each other in primary care, so tend to be thought about collectively, and they have an adverse effect on day-to-day functioning, including caregiving. In high-income countries, about 1 in 10 women who are pregnant experience one of these problems, and slightly higher prevalence, about 13% of women who've recently given birth. Next slide, please. Science was somewhat complicit in the neglect of this problem in low and middle income countries. That in these settings, two things occurred. Firstly, competing health priorities, especially of infectious diseases and malnutrition, meant that there was much less attention to mental health. But there were also authoritative anthropological papers that argued that women in these settings enjoyed traditional care, including an honoured status, rest for a dedicated period, social seclusion and gift giving that were protective of mental health, and therefore in these settings that they didn't experience perinatal mental health problems. And these were published in the 80s and 90s. And so it's not really until the year 2000 that properly designed epidemiological research was conducted in low and middle income countries. Next slide. If you could advance this, just press the button again, please. What these have shown us is that the weighted mean prevalence, both of pregnancy CMD and postnatal CMD, is at least 50% higher in these settings than it is in high-income countries. If you could press the slide again, the button again. But what it also revealed was this clear gradient in which the place where women were recruited influenced the prevalence. So women who were recruited in provincial or district health services rather than in tertiary hospitals in major cities had again a higher prevalence. And the highest prevalence was in women in the community who might have had very little access to health services. And this was particularly striking in the prevalence of postnatal depression, where 39% of women living in the community had a perinatal mental health problem after they'd given birth. Next slide, please. I think this is illustrated most readily by using these illustrative examples of well-conducted prevalence studies. In a high-income country, in a pretty rural city in Australia, only 4% of women, when screened routinely, have a perinatal mental health problem. But if we move then to an upper middle income country, a lower middle income country, and a low income country, you can see that the prevalence increases as the country's economic status decreases, and that the highest prevalence is in a country affected by humanitarian conflict as well as poverty, in the Swat Valley in Pakistan. Next slide, please. But what this slide shows us is that there's very much variety in the availability of data for countries about the perinatal mental health problems in their local settings. So the darker colours indicate that there's a large amount of local evidence on which to draw. There's a smaller amount in the pale blue countries, but the palest coloured countries have no evidence at all. So of the world's about 195 countries, only 77 have local high quality data on which to base their policies and programs. So a major disparity between high and low and middle income settings. Next slide, please. There's enormous variation in the quality of this data in terms of when it was collected, what sort of measures were used, whether they had been formally validated to establish local cutoffs, and whether or not diagnostic interviews had been used. Next slide, please. But these enormous variations in prevalence have been discussed by Vikram Patel, famous psychiatrist in mental health research, who says that this enormous global variety in the prevalence of depression and anxiety can't be attributed just to biological or hormonal explanations, because really no biological parameters show this degree of variability. Next slide, please. And so the risk factors for these problems are predominantly social and economic problems. They're the conditions in which women live, work, experience leisure, experience their relationships, and grow. The main contributor include these factors. So being in a low socioeconomic position or a member of a religious or ethnic minority group, having experienced hunger or food insufficiency are all associated with increased risk. The quality of a woman's relationship with her intimate partner is of fundamental importance wherever we investigate this problem. Her risk is increased if he is experienced as unsupportive, rejecting the pregnancy, or if he misuses alcohol. Family violence perpetrated either by an intimate partner or another family member is highly corrosive of women's health and well-being at any life stage, but very particularly at this life stage when in most settings women are confined to the domestic sphere. In countries with a strong preference for male children, women are usually held responsible for the birth of a girl baby. Criticism is a psychological toxin, and it's especially toxic when women are experiencing uncertainty and anxiety as they begin to learn how to care for a baby. And so if women experience their mother-in-law as critical and they're living in her household, this is harmful for mental health, especially if she's geographically separated from her own mother, as often occurs in some settings. Reproductive health problems also contribute if she's not had access to contraception and her pregnancy is mistimed or unintended or unwanted, if she's had a prior stillbirth, or if she's given birth prematurely or by cesarean. Having had a past history of mental health problems also really amplifies her risk. Next slide, please. But she's protected by having had more access to education. If she's able to have income security while away from the workforce to care for an infant, so she has some form of income generating work. And if she's given structured direct care by a trusted person in the first 30 or 40 days after giving birth. And women everywhere generally prefer this care to be provided by their mother rather than by another woman. And if her partner allows her to confide in him, is affectionate, trustworthy and kind, this also is very protective. Next slide, please. So this evidence has contributed to the extraordinary work done in developing the theory of change, which I think will make a transformative contribution to the recognition of this problem worldwide and to developing imaginative strategies to address it. So I'd like to pass over to Shannon McNabb.
Thanks, Jane. I'm going to take a few minutes to briefly provide an overview of what is currently being done to address these perinatal mental health needs of women in low and middle income countries. Thank you. To Jane's point, maternal mental health and women's mental health needs are not new. In fact, there are many things that we can build upon. At the global level, there are an increasing number of documents, whether guidelines or manuals, that are starting to acknowledge, in some cases, address the mental health needs of perinatal women. For example, the WHO just published their guide for integration of perinatal mental health and maternal and child health services. There are manuals for thinking healthy. There are alliances such as the Global Alliance for Maternal Mental Health, as well as regional alliances, such as the African Alliance for Maternal Mental Health. At national level, some countries are starting to address the issue seriously through changing policy language, adapting human resource plans, updating national training curricula to incorporate perinatal mental health into their existing guidelines and manuals. At the health systems level, which can include community and link to it or not, there are many interventions that are being tested and showing positive results when including perinatal mental health into, say, for example, ANC, PNC, as well as other innovative approaches. The community level is really where most of what's being done can be seen. It's through community health workers, women's group, early child development programs, and other existing platforms. Next slide, please. So this is an illustrative table to show that there are a diverse set of interventions or programs that have had positive results for both mothers and their children. However, what we do know is that what is missing right now is how to take these successful interventions to scale and sustain them, as well as how to implement interventions that have positive improvements in both women and children's outcomes. Next slide, please. As many are starting to recognize this is a challenge that needs to be addressed, they're looking for areas and places to intervene. There are five clear entry points that we found in our landscape analysis. The first is community level. Community health workers, peers, grandmothers, new mental health codders, which Linus will speak to in a minute, where they're able to meet women where they are as people and women that they trust. This also helps to engage women who are not seeking care at the health facilities. Children and family approaches, many approaches use children as, quote, Trojan horses for entry. This approach can remove the pressure, guilt, and stigma from the mothers and turning the focus instead on the children. Facility level ANC, PNC, so training healthcare workers to provide screening, referrals, and treatment. Provider pre-service education, training incoming generations of health workers to diagnose and treat common perinatal mental disorders. And lastly, there's a powerful link between mental health and spirituality and faith, and working with local traditional healers and faith leaders can be one of many strategies. Next slide, please. What are the barriers that women are finding to seeking and accessing care? So many of these are similar as those we see in high income countries: norms, stigma, expectations of what a good mother is. But given the significant gap that Jane mentioned, the mere existence of data and quality data, comparable data, and weaker health systems with human resource shortages that exist, these barriers can place significant burden on even the best intended interventions. And the lack of the policy level, at the policy level, that's explicitly tied to financial support is an important barrier that exists in almost all countries. I'm going to pass over now to my colleague Linus, who's going to talk about an innovative approach in Zimbabwe that he's been passionately leading for several years. Over to you, Linus.
Thank you so much, Shannon. It is my honor, to present at this very important time when we've been so advocating for maternal mental health issues for a long time, and having this theory of change being launched. Being guided by science, facts and research, I think most of us here, we are being convinced that investing in maternal mental health, I think, has got a lot of benefits. So even if we look at the facts on the ground, who has declared that, there's no health without mental health, but you see the focus has only been on physical health, and funding for mental health is non-existent from development partner. Hence, this is a crisis. So to be very honest, addressing maternal mental health issues is a process that needs a lot of commitment. So we of the Society for Pre and Postnatal Services in Zimbabwe, pioneering maternal mental health issues. We are working very closely with the Ministry of Health and Child Care and other partners and other regulatory bodies in Zimbabwe to make sure that there's huge recognition of maternal mental health. Next slide. So we realize that there is a very huge, in the deficit in terms of intervention. Yes, we are very aware, that there is a very huge shortage of mental health professionals or practitioners, being at city health, or being at central or at provincial or at district, hospitals. So in 2019, as an organization, we introduced our first world diploma in maternal, paternal, and child mental health to make sure that we close this very huge gap now. Because what is happening is, yes, we are raising awareness, we are doing whatever we are doing. But when you go now to these centers where most huge, percent of the population in our country, go to look for services, if they go there now, they cannot find somebody, who is there physically to make sure that they go through the process of, helping them, to address risks, mental, common, perinatal, common mental health problems. So we felt it's quite necessary, to make sure that this cadre is well integrated, at these, very critical points or, strategic, healthcare facilities, so that whoever comes with any physical health problems can also be, screened, or there's early, identification, of this common perinatal mental health. So our commitment as Society for Pre and Postnatal Services is to make sure that, mothers, children, fathers have access to quality, mental health services. Next slide. Yes, we come up with our family therapist model, where we are saying, yes, community awareness is very, very important. We believe that, we cannot work in isolation, and definitely there's great need, of the public now to be very aware of what the science is telling us, what the research is also telling us, and also the facts on the ground, to say, this is a very important area of maternal mental health, and we need to invest more, in make sure that there's a greater understanding, of maternal, mental health issues in terms of, education, prevention, of mental health care services across, the life cycle and the steps of care. So again, we find education and training very, very critical, considering that we are aware of the shortages of mental health practitioners at the centers that I alluded earlier. So we also felt that prevention, screening, and early identification remains very key. Early identification is very key because we want to prevent the coming of this severe and other mental health problems during the perinatal period. So early identification remains very, very key, in the promotion of perinatal, mental health issues, and also, having follow-ups, follow-ups and making a referral, as soon as people they get to the services, or when they get to these healthcare institutions. So we also believe that we need to do a lot of research, definitely at community level, because we believe that at community, these are the experts, at their own right, to make sure that they've got their own competence, skills, to make sure that they're able to address them, these issues collaboratively with them. So we felt that as at our model, we definitely need to have the community based prevention research. Also, we felt that it's quite necessary to have advocacy, so that we have the policies in place to support our programming. I understand that we may shortfall of the ethics, and we need to advocate for that. We may also shortfall of documents which support, or policies which support the provision of quality paternal and maternal mental health care services to improve the outcomes at the end of the day. So we felt advocacy remains very key as one of our pillars. So it is my hope that we are here together launching this theory of change, because we definitely want to make a very huge difference for our future generation. I thank you. Over to you, Shannon.
Thanks, Linus. And just to note, also a big congratulations is 3 days ago, the ministry established a register for family mental health therapists. So that's really exciting. So given this context that we've spoken about, how did we get here to this webinar today? Following our landscape analysis in September of 2021, MCGL, along with UNFPA and WHO, hosted a technical consultation to discuss the current state of maternal mental health and where to go from there. We came out clearly during that meeting, when we had over 700 participants, was that there was a call to do something in a more collective, collaborative way, a call to create a globally useful theory of change that can be used in any low and middle income country setting by a diverse set of stakeholders who may be in very different stages of addressing perinatal mental health. And so we brought together a group of experts from very diverse yet integral fields to start this process with us on a co-creation of a theory of change for maternal mental health in low and middle income countries. Next slide, please. Here's the list of those who participated and partnered with us in the work. We have participants ranging from local NGOs, women with lived experience, academia, and global institutions and organizations. It was a dynamic group, and one we're deeply grateful for their participation and collaboration. But now, what everyone's been waiting for, I'm going to pass over to our exceptional colleagues, Rohan and Aditya from Quicksand.
Great. Thanks so much, Shannon. I hope everyone can hear me. I represent Aditya, Rohan, and Isha, our colleague who's unable to join us today. And it's been such a privilege to work with everyone from the team who's here presenting, but also all the experts in really thinking through how one can co-create this theory of change together. We represent Quicksand, which is a design research and innovation consultancy based in India. Most of our work is in the development, humanitarian, and cultural sector. And we were brought on board to really specifically assist on the human-centered design piece. And at the heart of it, if we move to the next slide, was this commitment to iteration and flexibility, which was in the service of co-creation. So following the landscape review, what we did was set up a series of 4 co-creation workshops where we took these sort of experts through rounds of consultations following which we came up with the final outcome that you see today. A little bit about the process here. As you see, we start from empathizing and really centering users or key sort of people we want to work with in order to first define the problem and then to ideate and then prototype and test out what the solution might be. And really the intention with the iteration is to keep going back and forth with each step in order to redefine and better define the problem as well as who the users are and so on. If you go to the next slide, Quicksand specifically uses 3 tenets towards this human-centered process. Firstly, quite like what Shannon said at the beginning, really meeting people where they are so as to surface their needs and motivations and keep that at the heart of this journey. If you go to the next slide. The second piece becomes very much about telling stories because we think stories have the power to bring together teams as well as provide a rich and fertile ground from where to surface ideas, insights, and inspiration. And finally, crafting experiences. If you go to the next slide, which in some cases become toolkits for us. Sometimes it's a comic, sometimes it's a workshop, and so on. Such that these meaningful outcomes get represented in a reasonable manner. If you go to the next slide, particularly for this project, what we try to do at the beginning was to think about how, while we create this theory of change, really start with keeping the focus on women and really start by thinking about the lived experiences of the women as well as the healthcare providers. Here, the diagram that you see, this is a quick snapshot. We'll share with you links to the main document where you'd be able to go through the details. But as you see here, it talks about the lived experiences of women, their needs, the barriers that they face, as well as assets and opportunities available to them throughout their journey. So on the top, you see this linear journey from pre-pregnancy to pregnancy, childbirth, and postpartum. And while the woman's individual experiences at the heart of this, this also sort of surfaces questions or concerns around their relationship with their partners or their key family members, their relationship with their community, as well as the opportunities that they have in seeking care. If you go to the next slide. At the same time, the landscape analysis and consultation also uncovered critical conversations to be had around the mental health needs of healthcare workers. And so we decided it was important to also create a journey map for that. And to also say that, as you see here, while on the top there is an experience of providing care, which you see on the top layer, but at the bottom, there is also the impact on the personal life of the healthcare provider. And this is to realize that even people at the heart of providing care are in fact women in many cases who are going through their own journeys, often in these low income and low resource settings. And that's really, really important to highlight. It's also worth noting here that this was in fact an illustrative a process, right, where this was meant to be an entry point for participants in the co-creation process, such that they could humanize the evidence and inspire or feel inspired towards the co-creation. Every co-creation session started by revisiting and redefining or refining this, and we were able to borrow from all our experts' expertise as well as their personal experience. And this then became the starting point for the final theory of change. I'll now pass on to my colleague Aditya, who'd speak a little bit more about this and talk you through it. Over to Aditya.
Thank you, Rohan. I hope everyone can hear me, and really happy to be here. Before we move on to the actual theory of change and going through the presentation, we wanted to also focus a little bit on how we have structured the entire theory of change. And what we have done is we've broken down the global perinatal mental health theory of change into each individual layer of the social ecological model. This was done to allow for easier detailed viewing of the interventions, the outcomes, and the impact by layer. And we believe that it could be useful for users with a particular focus on one or more specific layers to be inspired and be able to find opportunities that are relevant for them. This is not to say, and we also realize this very early in the process, that there are a lot of interconnections between each layer and how the woman experiences perinatal mental health might not fall so cleanly within cleanly in one layer or the other. So the goal was to also figure out a design language or a way to show that while we are breaking this experience down by layer, uh, we realize and we want to reiterate that it all actually folds into this one common experience of the woman rather than a broken down experience as we see in the theory of change. So as I will come to that also in a bit, but as you will see, we have designed the theory of change to look like a, a folded document that is being opened up to show that although these layers exist independently, they all fold onto this one singular experience. And that's something that was important for us to highlight through the design process as well. We can move on to the next slide. Like Rohan mentioned, these are pages from the final publication, the package that we will publish soon, and you will receive more information on how to access that later in the webinar. So please don't be overwhelmed by the amount of content. You will be able to read all of it. And I will spend some time going into some particular sections just to call out the diversity and differences of how we've designed the theory of change. Overall, just to reiterate once that what the idea with the global PMS theory of change was to provide a common framework that can guide global thinking, investments, and programming when trying to improve the access and quality of care for PMS services. There are a couple of different layers to this. The first is, of course, the social ecological model that I spoke about in the previous slide. But each layer has been divided into interventions and outcomes. So if you see on each layer on top, we've listed out directions for interventions and what are our imagined outcomes that implementing those interventions might lead us to. And then as you see that all of these layers point together collectively fold onto this one impact statement that is on the right, which I'll just read it out. It's improved perinatal mental health and well-being through promotion, prevention, early identification, care, and treatment, resulting in better health outcomes for all women, children, and families. So the goal with each of the interventions in each of the layers is to sort of come together via its outcomes to this one common unified impact statement that went through quite a few rounds of iteration and adding and removing words as so we could ensure that it captures everything that is important and is also able to give a sort of a guiding light to organizations, teams, individuals that are working in this space. We can move on to the next slide. I'm going to spend some time diving into three of the layers: the interpersonal relationships, community, and service delivery. Given the paucity of time, we won't be able to cover all five. But like I mentioned earlier, you will have access to this resource. And the idea today is to give you just a sense of what we have created. At the same time, if you have any questions, feel free to put them in the question and answer section of Zoom, and we will try our best to respond to it when we come to that in the agenda. So the first layer that we are going to be focusing on is the interpersonal relationships. Here you can see that we've laid out the same content from the same diagram in a linear manner, just for ease of reading. There's a definition on top which we have for all. In this particular case, we're making it really clear that by interpersonal relationships, we want to highlight the intimate and personal relationship dynamics that influence a woman's perinatal mental health. And this involves the person's closest social circle. So their peers, their partners, their family members, and influences their behavior and contributes to their experience. So this is what we wanted to focus on with this layer. The interventions, if we start from the left, the first one focuses on using evidence-based approaches informed by highly contextualized concepts and language to engage women, partners, families, and companions, especially in vulnerable populations. The second one focuses on how it is really important for programs to offer gender transformative couples education and dialogue around not just perinatal mental health, but adjacent themes as well, like family planning, reproductive health, maternal, newborn, and child health. And all of this we believe not only helps improve perinatal mental health, but also male engagement in the process. The third focuses on how it is important to develop activities and programs that engage fathers on co-parenting and caring for their infants to shift the burden a little from just the woman in providing care duty. The fourth is to help identify any early signs of CPMDs through services for families of small and sick newborns. And the fifth is to integrate PMH into existing gender-based violence programs. And this integrate has come up as a big theme throughout, that we do not want to start fresh or build new or only, but also want to integrate within what already exists. There are very strong networks, there are very strong systems already in place that we want to make sure we are leveraging when thinking about designing programs or designing interventions in the future. The two outcomes listed here focus on communication and awareness. The first one is around how these interventions will help couples communicate more effectively and practice nonviolent and conflict resolution around perinatal mental health decisions. And the second one focuses on how partners and families will also become aware of perinatal mental health issues and support and respect all women to make decisions of their overall health and well-being. So this is just a quick snippet into what we have in the interpersonal relationships layer. We can move on to the next one, which is the next one, which is the community layer. Here, we've again defined what we mean by community. This also, through all of the co-creation workshops, went through many rounds of iteration, like Rohan mentioned, which is a huge part of our process. And we have finally been able to arrive at a definition, which is that it includes settings such as schools, workplaces, religious institutions, community groups, and neighborhoods in which socio-cultural and gender norms are defined and redefined. It includes broad societal factors such as culture, beliefs, values, norms, customs, and practices, but also at the same time includes community health workers or frontline workers who are often the first point of contact for an individual seeking healthcare services. So we did not want to let go of the idea that community health workers also play a crucial role in the community experience of the woman, and we'll also come to how they play a role in the health service delivery ecosystem as well. But we didn't want to let go of that key idea of how the line is not so clear between community and where community health workers might fall at the community level in a woman's ecosystem. Here, some of the interventions include conducting anti-stigma and discrimination campaigns through strengthened community mobilization and conversation. It's important to train, support, and supervise community health workers to screen, support, and refer women with CPMDs. It's important to deliver childbirth education, parenting, and self-care programs to enhance women's psychological well-being. A mental health cadre is very important within communities to be able to address the maternal health needs as well. Screening, support, and referral needs to be built into existing community-based platforms and groups that provide care, support, education, such as, for example, ANC or PNC group. It's important to introduce knowledge building and behavior change interventions for men as well, as mentioned in the previous layer, and create spaces where men can have dialogue and reflection around GBV. If there are any dialogue that's required between men, that is also an important space to create. And lastly, faith-based actors and traditional healers need to be partnered with to provide training. They need to be provided training on CPMDs and given resources for referrals and support. And programs need to identify what are appropriate roles that they can play as part of networks of care. And here the two outcomes that we have been able to dial down to is that one, community health workers and stakeholders in the community experience of women are able to identify and provide quality support and referrals for PMH care in a timely manner. Support and referrals depends on what your, I guess, background or role in the process is. Some stakeholders might be more important for referrals, while other for providing that quality support. And third, and the other outcome is that together as a community, we are working towards providing an inclusive environment to discuss and champion the health and safety of women and newborns during the perinatal period, respecting both their physical and mental health needs, somewhat like what we are doing today as well. This conversation that we are having plays an important role in changing mindsets, in raising awareness, and in creating an inclusive environment where these needs of health and safety needs of women can be discussed. We can move to the next slide. And lastly, for this presentation, we're going to highlight the content in the service delivery ecosystem. Here, again, we have had to go through many rounds of iteration to arrive at what we mean by service delivery ecosystem. And what it is for us is the point or the moments where clients receive services or care for perinatal mental health. The health system environment includes links between community interventions, primary healthcare facilities, tertiary or national facilities. And while we understand, and I've mentioned in the past, that the stepped care model crosses all levels, all layers from interpersonal to community to service delivery, this particular layer, we wanted to focus on health facilities and also include referrals from community to the facility level. So anything around the health facility level is what we wanted to focus on with this layer. Here, the first point, if you look at intervention, the first point is about using adapted and validated CPMD screening measurement tools for women during individual and group-based ANC, PNC child health intervention. So there are interventions that already exist. How can we use perinatal mental health screening tools during these interactions that interventions are already having with women? The second is, again, similarly, to use the screening and referral for women visiting GBV services, gender-based violence services. Then the next point is about competency-based training strategy that needs to be created for all health workers that might be able to inform or influence perinatal mental health care for women. And this includes pre-service and in-service trainings as well, where such information or training can be provided. There is also an important need to link providers with community health workers who are providing any sort of perinatal mental health prevention, care, and treatment interventions as part of their step care referral system. So how do we bridge that gap between the community health worker and the health providers or health facilities? Then the second last point is to provide mental health intervention support and services beyond self-care options to health workers as well. Because as we've got found in the landscape study, and like Rohan mentioned, health workers need to address their own mental health needs as well, and they need a space to do so. And that becomes an important part of the process to provide quality PMH services. And finally, integrating, as has come up before, PMH into existing efforts to improve the quality of service delivery, such as setting up safe spaces in facilities. The outcomes here are threefold. The first is that we imagine women have more access to high quality perinatal mental health services. Health workers and stakeholders feel supported, empowered, skilled, and have the resources to identify and provide timely, high quality support and referral for CPMDs. And finally, all women feel safe and satisfied with the quality of care available to them through the perinatal period. Yes, sorry, I know that was a little long and I spoke a lot, but this is just a glimpse into what the theory of change package contains and some of the behind the scenes thinking of why we have designed it in a certain way and what were our intentions behind structuring the theory of change as we have done. But yeah, with that, I would like to hand it over to Laura.
Thank you so much, Aditya. Next slide, please. So we really had so much rich and robust discussion throughout the co-creation process, kind of debating and considering what to include in the theory of change, how to represent ideas, and how to incorporate some really key principles and foundational elements. So within the theory of change package, we do have a section that's dedicated to outlining some of these key considerations and principles, these really foundational components that are essential to achieving success in perinatal mental health programming. And so we've showcased a few of them here. I'll just touch upon a handful in the interest of time. As Jane outlined in the very beginning, it's really essential that we're linking perinatal mental health programming to social determinants. So accounting for factors like poverty, like gender-based violence, like food insecurity, we know there is a really integral relationship between social determinants and perinatal mental health outcomes. So these interventions need to be linked and supporting each other. That perinatal mental health programming is embedded and integrated within existing service delivery platforms and not introduced as separate standalone programming. We also decided to make the theory of change broadly applicable across implementation contexts, but do recognize that particular groups and populations will need specialized and tailored approaches. So that might include women in humanitarian settings, it might include adolescents, it might include women who have experienced perinatal loss or obstetric trauma. We also really want to ensure that interventions for perinatal mental health are adapted and appropriate to local contexts. This is sort of good practice in any program design, but it's particularly important when we're talking about mental health. The way that people conceive of mental health, the language that they use, the terminology that's appropriate is really context specific. So we want to make sure that we are adapting for those contextual realities. Aditya talked to us a little bit in the interpersonal layer about the role of men. So we really wanted to make sure we were moving the discussion beyond just sort of conversation around male engagement to really meaningful inclusion and incorporation of men and their key role as partners and as fathers. Also making sure we're acknowledging the really critical importance of mental health interventions for health workers who are from these same communities subject to the same social determinants, often mothers, caregivers, and women themselves. They need to be supported for their mental health so that they can provide the best quality of care. We also wanted to make sure we were acknowledging the importance of networks of care that kind of cross between the layers within the social ecological model. A woman's network of care might include a traditional birth attendant, it might include a community midwife, it might include a specialist at a tertiary care facility. So we want to be programming with those networks of care in mind. Also recognizing that different countries and different programs are on different stages of implementation. So the theory of change was designed such that it's appropriate to settings that are just beginning to critically think about integrating perinatal mental health programming and those who are at a more mature place within the journey. Next slide, please. So just to wrap up here, how can you get your hands on these new materials? Well, we're giving you all a sneak peek today, but we will be posting these as soon as we've put the finishing touches on them. We will be posting them in these two locations. We'll be putting them up on the USAIDmomentum.org website, as well as on the AlignMNH.org website within the issues collection on maternal mental health. So we'll be following up this webinar with an email to everybody that includes the links for how to access these materials. And we're really looking forward to your ideas, your feedback, and continued discussion on this important topic, and want to hear how these materials are useful and applicable to folks. And so to begin that discussion, I'm going to hand it over to our moderator, Suzanne Stalls, who's going to be taking us through some Q&A.
Good morning, good afternoon to everyone. And for those of you that are following the questions in the Q&A box, you'll see that we have some very lively conversations going on. So what I'd like to do is begin, and as always, one of the challenges of this is time. And there are multiple questions that cover really important points. So we will do our best to answer those as we move through this list. So I'd like to take this opportunity to begin by asking Jane, Dr. Fisher, a question that I think actually is really an important one to consider, in that how do we see this theory of change being useful in either programs and programmatic approaches or research? So Jane, over to you.
Look, I think this document is, these resources are enormously helpful because they provide a high quality synthesis of the evidence, and they provide a very clear structure within which programs and policies can be planned. And I think one of the reasons that many countries don't yet have evidence is people can feel a bit powerless in the face of this complex problem. But what the theory of change gives us is a clear way forward, and a clear way of thinking about the fact that this moves beyond the health sector, and there are actions in diverse sectors that can be very helpful to families at this life stage, especially to women. So I think this provides a wonderful resource for countries, and I hope they couple it with addressing the importance of local data, and that without that local data, it's very hard to believe it's a local problem, and there are very good methods whereby that can be done. So the two together, the data and the theory of change, provide nations with a very clear way forward.
Thanks so much, Jane. And there are quite a few questions as well in the question and answer or the chat boxes that really show how hungry people are for very practical solutions to dilemmas that healthcare providers encounter on the ground. So there are a number of questions here that are addressed to Linus. And so Linus, I'd like to ask a few of them to you. One of them is, in the SPANS program, the program that you've initiated, is screening for maternal mental health problems included in any of the infant child health or nutrition services? So that, for example, if there is a problem with infant growth, we could begin to look more deeply to see if that might be associated with maternal mental health difficulties. So over to you, Linus, and thank you for your response.
Thank you so much, Suzette, for the question, and also the question from the participants. Yes, it is our commitment as Society for Pre- and Postnatal Services, and we won't left any child behind. I even mentioned that to say science is now clear, facts are clear that, during the first environment, the child can also suffer some mental health problems, which the mother faces, during the perinatal period. So it remains our commitment. Yes, we promote early identification. Why? Because within my context, women, they do express, they talk about these, mental health problems. So we know if we are going to have, these mild, moderate to severe common perinatal mental health issues, definitely there's need for a screening tool, to make sure that, every woman, every family member is not left behind. So that remains our commitment, and we hope to grow, to scale this program, the whole of the country, and we are open, to perfection as we progress. I thank you.
Thanks so much, Linus, and thanks so much for your work that really helps us understand and gives us a demonstration of what can be done, at a local level. So we have a question here regarding the theory of change, and the question is, and I'd like to pose this to you, Shannon, are nutrition services considered as a part of health services? Nutrition services aren't specifically mentioned in the TOC, but for example, services that, again, treat wasting, acute malnutrition are an entry point for screening and management. So again, that link between other, presenting clinical issues and how we might link that to providing services for women. So Shannon, if you could answer that question, please.
Absolutely. And in one of our significant findings in our landscape analysis was the important role that nutrition programs could play in terms of their platform that they serve for entry for perinatal mental health interventions. So there is evidence talking about malnutrition in women and their mental health, but then also there are strong nutrition platforms that exist that are really good opportunities to integrate some form of perinatal mental health interventions into. So rather than having these siloed programs, nutrition is a really important area to focus on. So it came up in our theory of change discussions. We couldn't list everything because there are early childhood development, nutrition, HIV, but absolutely that's a really important area.
Thanks so much, Shannon. So now I'd like to bring in another element of maternal mental health and another factor that certainly plays a part in that well-being or lack of well-being. And so these questions, I'm going to try to group them together. They're posed to Jane. And really, what does gender transformative couples mean? And would you consider this framework and theory of change that we've developed to be gender transformative? So over to you, Jane, and thanks for your response.
Thank you. I think there might have been an apostrophe missing, which was confusing. It was actually gender-informed couples education. And by that, I think what's most clearly meant is that transformative programs tackle harmful gender norms directly. And so they don't expect women to solve these problems alone. They have as a core to the program the benefits of equitable sharing of household work and infant care, and really educate people about the benefits of that for everyone, for the infant, for the woman, and for the man. And they also address the norms that underpin intimate partner violence and how deeply and profoundly harmful that is to mental health. And of course, this requires pretty important skills building in the facilitators, in the local community workers who may themselves be adversely affected by harmful gender norms. So it requires, I think, care and thought that this is not just about raising gender awareness. It's also about really using this opportunity to allow people to make the changes in their own domestic settings to become more gender equitable, for households to be safer, and we know mental health will improve through these direct effects on harmful gender norms and gender-based harmful behaviours.
Thanks so much, Jane. And I think, we can see as a reflection of these questions that the state of women's mental health is really has any number of influential factors. Obviously, and in some respects, it's stating the obvious, but nutrition, child well-being, and then also just looking at the profound influence that the woman's relationships and her intimate partners or family settings, and how that influences her well-being also. So I have a question for Becca, and Becca, the question is, and it's very complimentary, so thank you all very much. It said this brilliant work has emerged from a USAID initiative. What buy-in do we have so far from other international aid, health, women's organizations? And again, it would be great if we could all be on the same page and pull together, given the magnitude of the issue that we're seeing as we uncover more and more evidence. So Becca, over to you, please.
Thanks, Suzanne. And I have a little helper here with me this morning. Apologies. Yeah, no, thanks so much for that question. I mean, I think just seeing the incredible interest from webinars like this, from our global technical consultation that was held last year, where there were over 700 participants. There's a huge need and interest. We're also seeing many of our leading multilateral organizations across the globe elevate this issue. WHO, UNICEF, UNFPA, several other private donors are very interested in this space, and we are seeing small scale piloting and demonstration sites from small family foundations. I think we really need to just continuously advocate and talk about perinatal mental health as a component of maternal and child health at large, and ensure that it's part of regular conversations in that space. And so to that point, at the upcoming International Maternal and Newborn Health Conference next May, we plan to highlight and elevate perinatal mental health as a critical issue. I do think that there is an overwhelming sort of recognition that this is an area and a space that we need to prioritize and begin to really invest and work on, as others have said, how to take many of these demonstrated, feasible, effective interventions to scale. And I do see sort of an alignment across the globe in recognizing this. Thanks.
Thanks so much, Becca. And that's certainly good news. And we hope to continue to build on that good news. So there's a question here that I'd like to pose for Laura. It's concerning healthcare workers and their competencies in this particular service. So does, as a part of the focus on competencies of health workers to deliver this service, does this include facilitation, delivery of gender transformative activities? So again, I think, as we continue to kind of look at these questions, what we're seeing is just the kind of incredible confluence of factors that all profoundly influence both women's well-being, how the services are delivered, and what the demand is as well. So Laura, could you just briefly respond to that?
Yeah, sure. Thanks, Suzanne. And I really love that question. I think absolutely, as we think about how to build providers' capacities around perinatal health, it's going to be essential that we're thinking about the complexities of women's lives and their partnerships, and equipping them to be able to address those considerations with women and with their families. So I think absolutely there's room, there's space for us to be adapting materials, and it's critically important for us to be thinking about this element as we do so, whether that's in service or whether that's pre-service. And that's really going to be something that's going to need to be adapted per context in a way that's appropriate for women and families in different settings. Thanks, Suzanne.
Thanks, Laura. And here's a question for our Quicksand colleagues. Did the HCD-driven co-creation process include service providers and women from outside India as well? There you go. Rohan.
I think I just responded to that in the chat already, but the consultation included experts, many of whom were service providers. This included Dr. Prabha Chandra from NIMHANS in India, but also many from elsewhere, along with the comprehensive literature survey that Shannon was already talking about at the beginning. So this included resources and experts from India, but also many from outside of India. The complete list will also be in the package that you'll all receive. So,
thanks so much, Rohan. So another question, we'll continue to answer these questions as long as we possibly can before we have to wrap up. But here's a question that I think all of us can really begin to look at and think through as well. It says, thank you so much for a well thought out theory of change and breaking it out into individual, interpersonal, community, and healthcare components. The theory of change is a bit supply side driven to provide preventive, promotive treatment and care, but building individual, household, and community resilience to address these risk factors of perinatal mental health, and being able to problem solve by themselves by making informed decisions could also be an important impact outcome. I think that is a very thoughtful question, and I'd like to just throw that open to our panelists to see what their response might be.
I'm happy to take a stab quickly, and then Jane, you're coming in. I think it's really important that in one of the things that we've talked about, both during the theory of change creation and also that came out clearly in the technical consultation and landscape analysis, is that the challenge is not going to be solved in and of itself within the health sphere, right? There's education, there's gender norms, there's so much that has to take place. And so we absolutely agree that there needs to be work within the community, from the community, but it was also an interesting conversation of how much do you rely on the community to sort of take this on and then put the responsibility on. And so I think that this is going to be an intersectoral response, and it needs to be and continue to have conversations with various of these social determinants, who's talking to this group and that group, and bringing people together to make sure that it's not just the community health workers in and of themselves who are doing this, or it's not just at the health facility where providers are responsible for managing it. So I'll pass it over to Jane, but this has been an interesting and ongoing conversation about how this has to be a much more intersectoral collaboration, but at the same time, what can we do within the maternal mental health sphere?
Right.
Jane,
Shall I just add a small amount here? I think that we also, in addition to what Shannon has said, with which I completely agree, I think there are public policies that can have a big benefit for women's mental health, but that are not necessarily ones that individuals are even aware of. So public policies making domestic violence a crime that are actually properly implemented and enforced have in their own right an impact on perinatal mental health. Policies about reduction in poverty and in hunger eradication, similarly, if they're well implemented, they improve the well-being of everyone in the community, and they reduce the prevalence of mental health problems. So it truly is thinking about an intersectoral and multi-layered, from policies, programs down to individual provision of service. So it's not a simple problem like one that can be fixed with a prescription of a medication or a particular vaccine being provided. So I think it really does challenge us to think in much more complex and sophisticated ways.
Thanks so much, Jane. And here's a question for Linus. What do you see as the most pressing priorities that we need to address in perinatal mental health from here moving forward? So given your very practical experience on the ground.
Thank you so much. Yes, we had made a lot of noise for the past several years now, but still funding remains a very big challenge. So definitely we need to invest more in funding, and hence, addressing perinatal mental health, Verona's is not luxury. So definitely there's need to invest in the mental health, practitioners, because it's an outcry. Verona's there is a huge shortage of this mental health practitioners. So we don't want to make a lot of advocacy. And if women and families come to look for mental health care, they don't get it's the services which we're advocating for. Hence, so there's great need to invest in that. There's also great need to collaborate. I think Rebecca said it very well, to say, let's bring all these development, partners on board and see the great need for the future, for a better future generation. So yes, there's great need. And also we need to collaborate ourselves, as implementers, and also we need more research, especially in the low and middle income countries. And we need gatherings like this. Of course, currently we've got the Afrocentric International Conference and other alliances which are supporting maternal mental health, but we need more now, so that whatever little is happening on the ground is also being recognized. Thank you so much, Susan, for the opportunity.
Thank you so much, Linus. And I have a few questions actually that I think are best answered with Jane, having spent years as a researcher and academic in this field, and then Becca as a member of a donor community that can really help to push this agenda forward. So what are some of the suggested next steps? Where do we go from here? And how can we continue to coordinate and come together and really not only highlight this issue, but continue to build on the work itself? So Jane, Becca, if you could respond to that, please.
Becca, why don't you go first and I'll join in.
I think, and this was highlighted, I think, from Manasi in the chat, but there's so much to be learned, right? There's so much rich experience and expertise globally around the world in this space. We have so much learning to do. We need to be listening to one another. This is not a time for feeling as though we have all the answers and that there's a silver bullet to addressing perinatal mental health. This is a complex issue, and it requires a complex, in many cases, response. And so I think in terms of next steps, as I said, sort of listening to one another. And so with that, I'm going to plug, we have hopefully launching very soon a new community of practice around perinatal mental health that is really meant to serve as a information platform and exchange, an opportunity for service providers, for women with lived experience, for decision makers, policy makers, researchers to engage, ask questions, learn from one another, and to talk about opportunities for collaboration, for identifying ways to better advocate for perinatal mental health, to ensure that the communities are demanding perinatal mental health services or mental health services more broadly. And I really think having this community of practice that will allow for that international and global learning will really be an opportunity for folks to learn from one another, engage, and identify collective ways forward. Jane?
I completely agree with that. I think it can seem daunting to think all of this has to be done simultaneously. You've got to have policies, you've got to address gender-based risks, you've got to set up a screening system and a referral and service provision system. Nobody can do that overnight. No country can start from scratch and do that. But there are two things that I think are foundational to beginning to do this. First of all, it's eminently possible to set up a small demonstration project, and it might be in one site, but it is very important that data are collected and that it's disseminated and reported. So experiences of success, experiences of learning how to do this, the voices of people who've had a service provided to them are immensely important. And we know that if one starts, it suddenly expands in a country. And I would encourage you to look not only at these wonderful resources presented tonight, but also at WHO's Maternal Mental Health Implementation Guide, which provides step-by-step very helpful advice to health managers and service providers. I am an academic, so I want to put in a plug for the foundational importance of local data. And this means that I think often it's hard to do that. You don't know where to start, but this is where North-South partnerships can be very helpful in enabling countries to collect data. It doesn't need to be at a huge scale, but it does need to be done with rigor to actually identify, do we have a problem? What's the nature of the problem? Where does it reside in our communities? What are the sorts of things that women tell us contribute to them feeling miserable, unable to function as they would like to? And there are some publications that we can refer you to that can assist with that. I would really like this group as its next task to design a protocol for the very best epidemiological study. So countries don't have to design this for themselves. And we try and arrange for it to be done in multiple countries. It's not going to require a huge investment, but I think it would be very beneficial to fill the major evidence gaps that we have at the moment.
Thanks so much, Jane and Becca. As I'm looking, unfortunately, at our clock, which is ticking away, I realize that we're not going to be able to answer every question. I just want to acknowledge what an extraordinary variety of questions have come into the chat box and the question and answer function as well. And we will do our very best to summarize those. And when we send out both the PowerPoint itself that came from today's presentation and begin to link you with the resources that we are slowly developing, we will do our very best to answer the questions. And I think, as I look over the questions that have come in, I recognize what a heartfelt issue this is for so many people in terms of either their own personal experience or their professional experience and how this has affected them in what they do in their lives, both, again, professionally and personally. So I want to thank you all for sharing what you've shared. And we really appreciate deeply your interest, and we certainly hope to continue gathering that interest and moving forward so that we can focus our attention on this critical issue. So with that, what I'd like to do is turn it over to Kristen, who's going to help us create a word cloud. And I think in some ways this will help us really summarize what we're seeing as we begin talking about how do we create more focus and move this as a higher priority on the global and country agenda. So Kristen, if you can help us with that, I'd appreciate it. Thanks so much.
Okay, great. Thank you. So we are going to try to use this. It's called a Menti. So you can either go at the top, it says go to menti.com and then use this code, or else I pasted the link in the chat box, which will be even easier for you.
So I hope you all will give that a whirl, because I find that those word clouds are oftentimes such amazing summaries and representations of a conversation. So what I'd like to do in the few minutes that remain, someone's asking if we could repost the link. Just if you can go to the top of the slide and see, you just input www.menti.com and then use that code, and that will help you begin. And we can see already that many of those those aspects of care, those characteristics are beginning to come in. But first of all, I would really like to express our profound gratitude to everyone who participated and supported the development of this theory of change. One of the things that has been just such an extraordinarily powerful experience for us is just meeting these committed, dedicated professionals around the world who care so deeply about the well-being of women, and noting that there is no health without mental health. We hope that you'll continue to join us as we move forward with this conversation. As Becca noted, we will be launching a maternal mental health community of practice this month. And we intend to make this platform as broad and as accessible as possible so that we really can begin to use that platform as a means of driving impetus and creating, further interest. We want to stay action focused. It's been really clear from the questions in the chat box that people are hungry and eager to understand, how do we go about doing this? What can we do? What do we do when our resources are limited, and how do we prioritize and make the choices? That we will be sending to you our contact information for the maternal mental health community of practice. Anam Bhatti, one of our colleagues, will be heading that up, and will be sending you her email as well. And then lastly, a follow-up email will go out to all participants. We will try to summarize our questions and look at being able to respond to that. And also, as we said earlier, just providing links. So I'd just like to acknowledge in closing that we have had over 40 countries participate. So clearly this is a keen interest. And as you look at the word cloud that is coming up, with all of the words, there's gender, there's life-saving, there's empathy, there's love, there's commitment, there's urgency, and focus on community and empowerment. So I think we see just how all-encompassing this topic truly is, and we are eager to join hands with you and move this topic forward. So with that, I would like to close out, and again, thank everyone, thank our panelists, thank those our colleagues who have helped us move this forward. Thanks to USAID for highlighting this issue, and we look forward to the months and the years that come in order to advance this topic, its understanding, and to make sure that indeed all health encompasses mental health as well. So thanks very much, and we look forward to being in contact with you. Bye-bye.
Right.